Since we may be reaching the fire capacity, I'll get started. I do have a confession though, and that is that I thought this talk was starting at 1 o'clock. And so at 1 o'clock, there were about 5 people here. And I said, what the hell? Let's just do it. And someone said, Dr. Rosenblatt. So anyway, thank you all for being here. Hopefully, as people came in, they got one of these recipe cards. If you didn't, I have a few left up here at the end. But it's basically my recipe for doing awake intubation. So I'm Will Rosenblatt. I'm a professor of anesthesiology at the Yale University School of Medicine, practice at Yale New Haven Hospital. My practice is primarily head and neck cancer patients. I consider everyone in this room, if you're practicing, those of you who are practicing anesthesiology, if you're practicing anesthesia in an operating room, you are airway experts. The only thing that differentiates me and puts me up here is that I do a lot of difficult airway cases because of my practice. And I think you can call me an airway enthusiast, but also it's just the fact that I have so much volume. Okay, but that's the only thing that differentiates you from me. I don't believe anyone is that we all have to be experts if we're going to take care of patients. My disclosures, I'm on the AMBU advisory board. There's nothing that we're going to talk about today that's specific to AMBU, and I'm the owner of Airway On Demand that does, gives local classes in airway management, but no other disclosures. I do want to tell you about this. I'm a past president of the Society for Airway Management. We meet every September, but every 5 years we have the World Airway Management meeting. It's going to be a couple of weeks from now in Florence. I know it's late to make plans, but I do hope I see some of you there. It should be a fantastic meeting. Several organizations coming together. Really everyone on the planet who's interested and an airway enthusiast comes to this meeting, and it should be just a lovely time in Florence. So we're going to talk about awake intubation made easy. And we often look at awake intubation as something that's going to be time consuming and hard, difficult for you, difficult for the patient. But I think that if you have a plan and you follow that plan, it doesn't have to be hard on anyone, and especially if you alert the staff in the operating room that this is going to be done in the name of safety of the patient, and you have buy-in from them, you're going to have a much better experience. But what is the hardest part about doing awake intubation? And typically, if I ask a small group of people, they'll say, "Oh, it's the blocks. Oh, it's keeping the patient comfortable." I truly believe the most difficult part of awake intubation is making the decision to do it. And that was demonstrated in the NAP4 study in 2011 from the UK, where there were clinicians who looked at a patient, did an evaluation, said, you know what, this really should be an awake intubation, but they didn't really want to do an awake intubation. So they hemmed and hawed and they couldn't decide and they avoided it, and that's when they got into trouble. And that's why they got into the study, this NAP4 studies, but it only looked at complications. The curriculum we're going to talk about today, when do we do awake intubation? When do we choose to? Separating awake intubation from the fiber optic bronchoscope, the FOB. First of all, there are no more FOBs, they're gone. We now use flexible intubation scopes. The FOB, the fiber optic scope, is a technology that's no longer in use. It was fragile, it was expensive, and we have much better digital scopes nowadays. We're going to talk about my personal recipe for awake intubation. And if someone does awake intubation, they have and they're successful, they have their own personal recipe, and I don't want to change that recipe if you're successful. I'm going to offer mine on that index card if indeed you need a recipe to call your own. So we're all familiar with the difficult airway algorithm. It was produced in 1993. I have a lot of disagreements with this algorithm. But the one thing that I can agree on is that when it came out in 1993, it was a vanguard. It was a brand new concept that you could write an algorithm for deciding how you're going to manage and how you manage a patient when you get into trouble. In 2003, the LMA was added. In 2013, video laryngoscopy was added. And then in 2022, when the last version came out, it had some interesting changes, but I think as you can see, the structure was maintained the same. Now, one thing about this structure, from 1993 to 2022, 2022 is that there's two distinct pathways. One was awake intubation and one was intubation after the induction of general anesthesia. So two pathways. One of those pathways, awake intubation, is something that a lot of us don't do very often and may not do at all. But yet the ASA dedicated so much space to that algorithm. I think that what that told me way back in 1993 when I was just starting my career to today is that the ASA considers it an important decision that you must make in every case that you manage a patient. You may never do an awake intubation, but it's something that you have to think about. There are other problems, fundamental problems with the ASA algorithm. And again, I respect that it was the first time that anyone ever tried to put an algorithm together. First of all, these two distinct pathways, awake intubations versus intubation after the induction of general anesthesia, but there was no guidance to choose one or the other. That has been, for the most part, resolved with what's called the decision tree tool. We're going to talk about that in detail. The box that the vast majority, 99+% of your patients are going to go into, that is intubation attempts after the induction of general anesthesia, only starts with intubation and general anesthesia. And I know that people in this room do a lot more than intubation, and the people in this room do a lot more than general anesthesia. So really, it doesn't apply to many of your cases. It was complained that these were rigid pathways where when you're managing an airway, it's dynamic. It said limit attempts at intubation, limit attempts at doing things like a supraglottic airway. What does that mean to limit attempts? People called it complicated, not a cognitive aid, and there was a question of what are you going to do if you fail awake intubation? What's your next step if awake intubation fails? Didn't answer those questions. And so the task force of airway management, difficult airway management for the ASA, developed a new tool in 2022, and that is the difficult airway infographic. And the infographic has three panels. The decision tree tool that I mentioned is identical to the decision tree tool in the ASA algorithm because, by the way, if you're unaware, when the last iteration came out in 2022, they published the old algorithms I just showed you, and they published the infographic three panels side by side. So to kind of add to the confusion. There's a couple of seats up here. There's a couple of seats scattered in the middle if you guys are interested. So decision tree tool, the awake intubation pathway, and very important and not to be discussed today, management after the induction of anesthesia pathway. That is management, whatever management is to you, whether it be an intubation, the supraglottic airway, a face mask, or a nasal cannula, and induction, whether that induction means general anesthesia, regional anesthesia, sedation anesthesia. So this applies to all your cases. We're not going to discuss that today. So the decision tree tool, again, what we're talking about is the decision to do awake intubation or not. 4 element assessments when considering the airway. Do you suspect difficult laryngoscopy or intubation? Do you suspect difficult ventilation with a face mask or supraglottic airway? Is there a significant increased risk of aspiration? Is there an increased risk of desaturation or decompensation? Each one of those assessments I just mentioned should be made by the clinician who's managing that airway. Can't be done by a colleague in pre-admission clinic. It can't be done by an attending telling a CRNA or a resident. It has to be done by the person who's doing the airway management, using the techniques of their choice and in consideration of their experience, available resources, including who's there to help them, okay? Very important that that person, based upon their resources, make that decision. So consider 2 clinicians looking at the same patient, and they differ in their training, their experience, the setting, what's the available skills and tools that they have, and one might choose to go into the induction of anesthesia pathway, the other one may choose to go into the awake intubation pathway. The ASA wants to know which one of these is correct. Both are correct, okay, because it's based upon your personal assessment. Now, let's go back in detail, because again, this is how we decide to do an awake intubation. You look at the patient, you evaluate the patient, I don't care how you evaluate the patient, the way you choose to, and you ask the question, do I suspect difficulty with laryngoscopy, whether that be video or direct laryngoscopy? Is it going to be rapid and efficient to manage this airway and put a tube in? Why a tube? because putting a tube in the trachea is definitive, what we consider, I hope, archetypal definitive airway management. So that's the one we're going to say, if I get into trouble with a regional anesthetic, am I going to be able to put a tube in this patient, okay? If the answer is no, I don't expect a difficulty, I can drop down to the induction of anesthesia pathway and I can do whatever appropriate at that time. Maybe it's a rapid sequence, maybe it's an LMA, maybe it's a nasal cannula, maybe it's a, just whatever airway of your choice. But I know that if I get into trouble, I can put a tube into that patient. If the answer is yes, and I don't mean absolutely difficult, it could be just this is going to take me more time and more effort. It may give me a little bit of problem. If the answer is yes, then I'm going to ask the second question. Well, and remember, we're just evaluating the patient in the holding area. Well, do I suspect difficulty with ventilation if I can't intubate that patient right away? And that's in ventilation with a face mask or a supraglottic airway of your choice. If the answer is yes, I'm in the potential for a cannot intubate, cannot ventilate situation, just the potential. I'm still in the holding area, which is great, but I can make the choice to do an awake intubation, okay? Let's say I don't expect any problem with ventilation. I suspect that maybe this patient might be a tad difficult to intubate, but I expect no problems with ventilation. I ask the question while I'm trying, and I'm going to apologize for my language, while I'm dicking around trying to intubate this patient, are they going to aspirate? Okay. If I suspect a significant increase risk of aspiration, I'm now in a cannot, really should not ventilate situation. And in this case, once again, I'm going to choose awake intubation. Let's say no aspiration risk. Nothing is making me suspicious. The last question I'm going to ask is, let's say I screw up. We are fallible. We're human. We're fallible. We can make bad decisions. Let's say we make bad decisions. We can't manage that airway. Is this patient going to rapidly desaturate and not give us time to fix the situation? If the answer is yes, I can do error mitigation, decision error mitigation. Once again, if I screw up, this patient's going to desaturate and maybe get harmed. I'm going to bring the patient to the OR and do the awake intubation instead. If the answer is no, even though the patient may be a little bit difficult to intubate, I'm going to go into my routine induction pathway, feeling safe that I can manage that patient, even if I can't get a tube into the patient immediately. One more seat up here, guys, if anyone wants to take a seat. So these are 4 inductive assessments that you make decisions based upon your experience and your tools. And they lead to objective decisions. So inductive assessments, going to objective decisions. Now, why the doves? Okay, the doves are there because I think this is liberating. Why liberating? Because you get that awful looking patient in the holding area and you say, oh my God, do I have to do an awake intubation? Is this something I've got to do? Well, if you are honest with yourself and you go through these and you come out with one decision or the other, you're obliged to do that. There's no choice. And if you don't have experience with awake intubation, you find a colleague. Or if you're in an ambulatory surgical center, you say, no, this patient is not appropriate for this ambulatory surgical center. Before you've gone to the operating room, you tell the surgeon, we're referring to an inpatient setting. So this is a liberating device. Now, let's say we make the decision to do awake intubation. We're going to talk today about preparation for the awake intubation. We're not going to talk about block as like the only thing we're going to do. Preparation doesn't mean just block or topical anesthesia. We're going to talk about awake. Awake does not mean the patient's smashed or wasted or Glasgow Coma score of 3 based upon everything you've given to the patient. What awake means is that the patient may have some sedation with cooperation. They have to be cooperative. Awareness, if amnesia is there, that's great, but they don't have to have amnesia. Most importantly, they can control their own airway and they can respond to commands from you. Also, it's not synonymous with fiber optic intubation, right? Here I'm doing a video stylet. Here I'm doing a video laryngoscope. I've prepared the patient the same way. So it's not synonymous with fiber optic intubation. Any device that you use in the asleep patient, you can also use in the awake patient. This is one study that looked at video laryngoscopes versus a flexible scope for awake intubation. There was no difference in the failure rate, the first attempt success rate, patient satisfaction, adverse events. You don't have to be an expert in a flexible scope to do an awake intubation. Use the tool that you feel really comfortable with. There are actually some advantages to using a video laryngoscope for an awake intubation. As I just mentioned, you may be more familiar with the video laryngoscope than a flexible scope. There's a wider view. When you're using a flexible scope, for the most part, you have this very narrow view of the airway. And you can manage a very wide view of the airway, seeing other anatomy if you're using your video laryngoscope. And you all know this, that you can vary the view with it. So that's a real advantage. No limits on tracheal tube diameter. Let's say the only flexible scope you have available to you is a pediatric scope or a small adult scope, and you've got a big guy that you've got to put a big tube into. Well, then you've got a problem with potential hang-up. A big tube, small scope, you've got a cleft there, you can get hang-up with the tube. That doesn't exist with video laryngoscopy. You don't have to worry about hang-up, the difference between the stylet device, in this case a flexible scope, and the tube. That's a topic for a different discussion. You actually have a view of the intubation. If you think about it, when you're using a flexible scope, you're looking at the lower airways you put the tube in. You may not see trauma that occurs, but if you're using a video laryngoscope, you get to see the actual intubation. You get to see the tube passing through the cords, trying to avoid trauma. So there's definitely advantages, and there's some data that it may be faster than using a flexible scope. We can use supraglottic airways. Here's a woman who's now this is an old video, but this woman's being intubated with a fast-track LMA several years ago. So you don't have to use a laryngoscope of any kind. This is actually a blind intubation. You could certainly do this with a supraglottic airway and a flexible scope going through the supraglottic airway. Any device used in the asleep patient can be used in the awake patient. So let's talk about the prep. How do we get that patient to a state that they're comfortable for the intubation? Now, first thing I want to say is that I think I said this, but people who came in the room, if you've got a technique that works, I don't want to change it, okay? If you've got a technique for awake intubation, you've practiced for years, patients are comfortable, that's fine. I don't want to change it. What I'm offering you is my recipe, and I have those cards. I have a few more cards up here that have my recipe on it. And I have other people in my institution that use a completely different recipe. Do what you do. This was a study that looked at 30 different studies on awake intubation, 37 different studies on awake intubation. The only difference they found was that when dexmedetomidine was used as the chief sedative, there was less episodes of desaturation, okay? But as I discussed with the small group that was here earlier, it probably is tied into a lot of other things you do, how you give your local anesthetic, how much absorption there is. So you may be very successful with something besides dexmedetomidine. I've actually switched to dexmedetomidine in part based upon this study. So diverse techniques of pre-med sedation, the success of these 37 different techniques was the same. Complications were very low. Satisfaction for the patient was the same. Less desaturation events with dexmedetomidine. So we're going to look at what I call a 6-finger approach, and I'm tempted to make a 7th finger on it, which I'll mention at the very end, but it's going to get a little crowded. What are those 6 fingers? Explanation, desiccation, dilatation, topicalization, sedation, procrastination. Now, what's procrastination? In this case, it's time management. It's going to take more time. You've got a busy list. You've got a busy center. You're going to have to manage your time a little bit more. But remember, you're talking about patient safety. So explanation, I always explain to the patient exactly what I'm doing to them, and I explain why, and I coach it in the idea of safety. I'm doing this because I want to keep you safe. Safety, Mickey says safety first. And patients understand safety. So I generally say to them, your anatomy differs a little or a lot from the normal, and in order to keep you safe, I need to take a look with an instrument. We're going to take our time, make your throat numb like the dentist does, but I'm not going to use a needle if I don't have to, okay? And patients, by this time, they understand exactly why I'm doing it and that my intention is to keep them safe and comfortable. Desiccation, use a drying agent. As long as there's no contraindication like closed angle glaucoma or uncompensated or compromising atrial arrhythmias, I always dry out the patients. There are clinicians who don't do this, who allow the patient to make secretions. I think this is a key element, is to make sure the patient is dry. Why? Saliva is a barrier to topical anesthesia. Topical anesthesia is a poison, okay? It poisons, or local anesthetics are poisons for sodium channels. And what the body does is it makes saliva in order to protect the mucosa from that poison. It protects the mucosa. It's going to dilute your wonderful 4% lidocaine. It's going to dilute it down, and it's going to remove it. The patients are going to produce lots of fluid. They're going to swallow it. They're going to spit it out. Get rid of that saliva. Saliva is a barrier. So this airway has not been prepared. It's going to be really hard to prep this airway for an awake intubation because of all that saliva. And as I put in topical anesthetic, it's only going to get worse. It obscures the view. Most likely we're going to use an imaging device or an optical device to intubate this patient, and it's going to obscure my view with a lot of saliva. And the saliva is going to start acting as a foreign body. It's going to start causing more gagging, more coughing. So I'm going to use a drying agent. My favorite is 0.2 to 0.4 milligrams of glycopyrrolate, IV or IM, as I have on the card. If the patient doesn't have an IV, I've got a busy list, nurse is busy putting in an IV, I'll give it to them IM. I'll come back 15 minutes later, 10 minutes later, ask if they're dry. I'll do it again if they're not dry. And I've already checked to make sure they don't have any arrhythmias or closed angle glaucoma. I'm going to start early. I'm not going to give it as we go into the operating room. I'm going to give it early because it's going to take 15 minutes to reach peak effect. We're going to dry up. We're going to do our topical technique that we'll talk about later. Dilatation. Dilatation is a reminder to me to remind you to always prep the nose unless there's a contraindication. If you're planning an oral intubation or a nasal intubation, I always prep the nose. If there's chronic epistasis, history of coagulopathy, HHT, pregnancy, anatomic obstruction, I'm sure you guys can think of more, I will avoid the nose, but otherwise I'm going to prep the nose, even if I'm planning an oral intubation. Why? Local anesthetic in the nose is going to reach my field. It's going to reach the pharynx, it's going to reach the hypopharynx. And it can be done while you wait. While you're waiting for the glycopyrrolate to take effect, you can start prepping the nose and you're going to start to get your block. Also, can be some cross innervation from the nose down to the pharynx. So again, by prepping the nose, I'm starting my block early. Probably the most important one is if you have a plan change. Let's say you get into the OR and it turns out that, in fact, I've been saying this for years here at the ASA. You get to the OR and maybe the patient has this horrendous gag reflex you can't get around. Well, there's actually less of a gag reflex if you go through the nose because the flexible scope is not hitting directly on the pharynx, it's hitting tangentially. I've been saying this for years, I had a patient about a year ago who would not tolerate an oral flexible scope awake intubation. I switched to the nose and she was fine. Okay, maybe the surgeon announces, hey, it's an OMF, I'm gonna close the teeth at the end of the case, I need a nasal intubation, and you weren't expecting that. Well, you always prep the nose, it'll help you out. So this is a nose that has not been prepared, and there's very little room to move. You can see the blood vessels in the mucosa, it's boggy in there, but if we take that same anatomy and we give them a vasoconstrictor, here we have much more room to work, and it appears much less chance of bleeding. Those vessels are, for the most part, gone. We're going to talk and use this patient as an example. This is a patient who had surgery and radiation at Yale many, many years ago, and then showed up at another hospital in Connecticut with lateralizing signs. And it turns out he had radiation necrosis of one of his vertebra, and he had some collapse, and suddenly he had lateralizing signs. They attempted an awake intubation, it failed. They then put the patient to sleep, which I think was a terrible idea. They still failed to intubate the patient. They sent the patient to Yale, saying that the patient, it was an impossible intubation, is going to need an awake trach or something like that. So transferred to Yale. We, of course, wound up doing an awake intubation, and with the exact same technique I'm going to talk to you about today. And there you see the patient in his non-invasive collar in the OR. he's actually, you can't really tell, but he's actually looking at a screen, and he's curious about all the anatomy as it goes by. And he was very curious about what he was looking at and what we were doing. He was great. He then had a cervical fixation, and a year or two later came back to us for another procedure. He's still a very difficult airway. You can see the radiation changes. You can see his neck is very stiff. So he was in awake intubation, and a lot of the video I'm going to show you is based upon this patient. So dilatation. How hard is dilatation? I take an Afrin bottle or an oxymetazoline bottle, squirt, squirt, and I've got my dilatation. While I'm waiting for my glycopyrrolate to work, I do that a couple of times. Now you saw that Afrin bottle there. I want you to remember that Afrin bottle, the oxymetazoline bottle that I just squirted him with. I try to avoid nasal intubation. Even though I'm going to prep the nose, I try to avoid it. Why would I possibly want to do nasal intubation with a patient awake, or asleep for that matter? Well, it's actually an easier course for my flexible scope, less acute changes as it goes around the curve. So that actually makes it a little bit easier. As I said before, there's reduced gag when you do a nasal intubation with a flexible scope as opposed to doing awake intubation through the mouth. Let's say the patient, again, has trismus or the surgeon plans to wire the mouth. Well, why not? Why do I try to avoid doing a nasal intubation if I can? Primarily because of trauma. We get bleeding, which happens in 20 to 55 attempts. A lot of pain. Even with your best blocks, it's hard to relieve the pain from a nasal intubation. There's episodes of sinusitis, bacteremia, turbinectomy, and something I think that we don't recognize often, and I think does happen, and that is retropharyngeal dissection. Now, I want you to look at this patient. It was an awake nasal intubation, and as I play the video, concentrate on the circle. So I'm putting my tube through the nose, everything's going fine, and look at that, okay? That is actually a tube that has gone submucosal. And I think when you have a lot of bleeding and obstruction during a nasal intubation, I suspect this is happening more often than we know, and in this case we backed it out, maybe we changed sides, did some rotation, got it in. This was very worried, and this is not hyperbole. This patient was an attorney, local in town, but you know what? She and I had become very friendly during the pre-op process, and interview, and I told her exactly what happened and why I was concerned that we were going to follow up with her. You can see all the blood in that tracheal tube once we switched sides and put it in. Topicalization, and I apologize. I think she was asleep. I don't think that was an awake. That was asleep, but of course we can do the same trauma with a awake intubation. Topicalization. I just plan to cover 3 areas, and it doesn't matter if I'm doing a flexible scope, if I'm doing a video laryngoscope. I do the same techniques every time within the limits of the patient anatomy. Some patients have had a lot of things cut out. They've had radiation. They can't open their mouth. I do whatever I can to do these 3 techniques: nasal, oropharyngeal, hypopharyngeal, nasal, laryngeal, tracheal. And I'm going to start it in my holding area. I'm not going to wait for the OR. As soon as my glyco takes effect, I'm going to start it. And we're going to look at these in terms of the nerve supply, the location that we're blocking, and what the effect is that we hope from the block. So for the nasal, it's the trigeminal nerve, it's the nasal mucosa that I'm blocking, and all I'm trying to do is block that nasal pain. And if we look at the innervation, we have the anterior ethmoid nerve covering the anterior 1/3 of the nose. We have the lateral nasopalatine nerves coming from the sphenoid sinus, sphenoid bone out, covering 2/3 of the nose, and also the hard and soft palate. I simply take swabs that are filled with lidocaine. My favorite agent is an ointment, 5% ointment, if I can get it. Recently, the price jumped a couple of years ago. Price jumped from something like $25 a tube to $135 a tube. My hospital pharmacy committee blocked it, and then we were able to get it back. But I'm just going to take a couple of swabs, and I'm going to move it back until I hit the sphenoid bone. And so here, this woman, we're taking a Q-tip, we're following along the hard palate, over the hard palate, and we're pushing it in until the point that we feel the sphenoid bone, that we hit the sphenoid bone. And you can imagine that where the swab going down, the best I can, I'm going to stay under the inferior turbinate. I'm going to stay down here. And I'm going to go until I'm keeping under the inferior turbinate. There's less pain there. And we're going to go until we feel, you know, when you do a needle block, an epidural, spinal, and you hit the bone, that's what it feels like when you hit the sphenoid bone. I'm going to do a technique called push to pain. I never want to hurt my patient, so I'm going to place it in. As soon as the patient winces, I'm going to back away. I'll come back a minute later, I'll go a little further. Some patients you go all the way back, some patients it's going to take a while. As I said, my favorite agent is this 5% ointment if I can get it. I can also use 2% viscous, 2 or 4% injection if I don't have my 5% ointment. Here we're using a viscous, and I have it on a catheter. By the way, that's a angiocath, but I've removed the needle and I showed it to the patient and I said, this is not a needle, this is just an angiocath. I'm not going to use any needles in your blocks. And I'm just depositing maybe 50 or 100 milligrams of lidocaine on both sides of the nose. Now remember that Afrin bottle. Here's a neat trick. If you take an Afrin bottle or oxymetazoline bottle, you can break off the atomizer, pour out the oxymetazoline, fill it with solution lidocaine, and now this becomes an atomizer for lidocaine. I love this. If anyone is aware of the preoperative endoscopic airway evaluation, where we use a small flexible scope in the holding area to evaluate airways, this is what I do. A couple of squirts and they're numb in the nose. Let's turn to the oropharynx. It's the glossopharyngeal nerve. I'm going to get the pharyngeal wall in the posterior 1/3 of the tongue, and what I'm trying to block is the gag reflex and the glottic closure reflex. I'm going to look for the palatoglossal arch. That arch of tissue goes from the palate to the tongue, palatoglossal arch. I'm going to take, because I'm a reasonably nice guy, I'm going to take new pledgets, okay, filled with lidocaine. I'm going to put it right against those palatoglossal arches on both sides. And so far I've used about 200 milligrams of lidocaine. Now this is my dentist, Dr. Goldberg, okay? Dr. Goldberg taught me a really neat trick. He taught me tongue control. When he does an exam, looking at my lymph nodes and so forth, what he does, he takes a 4x4 gauze, he totally unfolds it, he refolds it nice and long, puts it on my chin, and then wraps up my tongue. And he can do whatever he wants with my tongue. He now has control of the tongue. It's not a question of just grabbing the tongue, it's getting real control of the tongue. So that's what I'm doing with this patient. I'm going to wrap up the tongue. The tongue is a very strong muscle. I now have control of it, and now I can get those pledgets exactly where I want. Okay, so I'm going to put them against the palatoglossal arches on both sides. Here we have our patient. We're going to wrap up the tongue, and this time I'm going to use a technique called push to gag. Once again, I don't want my patient to be uncomfortable, so I'm going to go in there, and as soon as the patient reacts, I'm going to stop. Maybe I'll come off. If he has a bad gag, maybe I'll come off a couple of millimeters. Go back in a few minutes, or maybe a minute. Sometimes I have to paint the lidocaine onto the palatoglossal arch, being very gentle. If I take my time, I'll get that gag suppressed. Here's a patient where I didn't have my ointment, but I took a gauze pad, I soaked it in 4% lidocaine, and I'm putting it with a forceps right against the arch, and I'll do that on both sides. Hypopharynx, larynx, and trachea. Vagus nerve, those are the areas we're blocking, and what I want to block is laryngospasm and cough. I'm going to take a syringe. This is a technique I learned from a pulmonologist. Take a syringe of viscous or solution of lidocaine, 2% to 4%, on an angiocath with the needle gone. I'm going to show the patient the needle's gone. I'm going to put it over the tongue, and I'm going to let it drip. And the patient, I don't know if you could hear that, but the patient will cough, meaning it goes into the right place. About 100 milligrams of lidocaine, what I'll use, 2 or 4%. Here in this case, I'm using viscous lidocaine. And I tell the patient, and I'm going nice and slow, I'm not going to jam it in there, I'm going nice and slow, tell the patient, you're going to cough, or if they do cough, I say, that's exactly what I want. That lidocaine is going exactly to the right spot. I want it in your larynx. Now, why am I holding the tongue? In the first case, I held the tongue because I wanted to get the tongue over to the side so I could put the pledgets against the palate-glossal arches, right? This is different. I'm holding the tongue this time because if you hold someone's tongue, they can't swallow. I don't want the patient swallowing the local anesthetic. I want them to aspirate the local anesthetic. I want to get it down to their larynx, trachea, and beyond. So here we're going to use tongue control. We're going to wrap up the patient's tongue. I'm going to take my local anesthetic and I'm just going to dribble it over the patient's tongue. And I'm talking to the patient throughout this, and it's going to take time. You're going to have to take some time doing this. So far, 300 milligrams of local anesthetic. I like these little atomizers. I'll do the same thing where I can put it over their tongue with tongue control and spray it so that, and ask them to inhale as I spray it down, hopefully getting more of a block that way. Now, if I'm using a flexible scope, I might add some more anesthetic to the situation. I'm going to use what's called an Ovasapien catheter. In 1992, Andy Ovasapien described using an epidural catheter through the working channel of a standard flexible scope. In this case, it actually was a fiber scope. Okay, this was before the digital scopes. And as you put it in, it'll go through what's called the working channel, come out at the objective, and the beauty of this is that you can aim the local anesthetic exactly where you want. So there we see the local anesthetic coming out of the tip, and we're able to aim it exactly where we want to have it. So in this case, maybe I get a little bit on the cords, maybe I advance the catheter through the cords to the larynx, maybe I go back and do the epiglottis, but I can get local anesthetic where I want. Now, the advantage of doing this above putting a syringe of local anesthetic directly down the working channel without the epidural is I can see what's happening. If you take a syringe of local anesthetic, you hook it to the working channel of your flexible scope, and you squirt it, it's going to blind you. And if the patient coughs, the end of your scope might wind up anywhere. But in this case, not only can I direct the epidural catheter, I can also see exactly where it's going. This is a case of a patient who had a prior tumor, maybe a resection, definitely some radiation. And at this point, the patient is not ready for me to stick a flexible scope into their larynx, but I can put a tiny epidural into their larynx. So here I am advancing the epidural past this mass and depositing local anesthetic down beyond the mass. So a very, very helpful tool. If I'm using a if I'm using a video laryngoscope, maybe I'm using this atomizer, and I can now aim local anesthetic directly at the parts of the larynx. And even if the patient's ready, put that flexible atomizer through the vocal cords and deposit local anesthetic below. I'm doing progress, right? I'm progressing down from the tongue. I don't even worry about the mouth, but I'm the posterior third of the tongue progressing down to underneath the vocal cords. So far I've used 500 milligrams of lidocaine. I think I slipped a couple of times and said lidocaine. I meant to say local anesthetic. Why lidocaine in particular? There are so many different choices, so many things that you could use in your armamentarium. Number one, there's multiple preparations. Lidocaine comes as solution, it comes as viscous, it comes as an ointment, it comes as a jelly, it even comes as a spray. So you have a lot of choice as to how you apply it to the patient's airway. And then it comes in multiple concentrations. So I can choose, depending upon where I'm applying it, different concentrations. Actually, I'll use the highest concentration that I can of the preparation that I use, whether it be on a Q-tip or squirting it down the airway. I can also do easy dose calculations. By using lidocaine in all these different blocks, I can calculate how much I'm giving to them. And this brings up the topic of toxicity. These are studies that looked at the nasal and swallowed lidocaine, and this was done by pulmonologists. So if you apply topically 400 milligrams of lidocaine, this is from a study, into the airway, you're going to get a level in the blood. About an hour later, it'll peak at 0.5 mics per ml. Now, these guys use the benchmark, pretty standard benchmark of 4 mics per ml as a toxic threshold. So you can see that 400 milligrams, they were well below the toxic threshold. They then applied 800 milligrams of local anesthetic to the airway, and they reached 1.8 mics per ml, so still well below the toxic threshold. There's other techniques like using atomized lidocaine, and this is a very good technique. You will get a very good block with this technique. The only thing I want you to be concerned about is the levels in the blood that you get. So atomized 400 milligrams, 2.8, we're getting kind of close to that toxic threshold. And if we use 800 milligrams, we can get a frankly toxic level of lidocaine in the blood. So as I said a second ago, atomized lidocaine is a great technique. You're going to get the whole airway, the pulmonary tree, but you have to be willing to accept higher blood levels. And if you have a patient who is toxic, febrile, sick, cachectic, wasted from the ICU, you may reach a toxic level. Those of you who come to WHAM, there's actually a case report that my duty is to present that case report and have an expert discussion about it, about you can, in these toxic patients, get high levels. Why is that happening? Pretty simple. If you atomize or nebulize, you're getting way down and you're getting absorption, possibly at the alveolar level. And there's been studies that look particularly at this, atomized versus topical lidocaine, the bioavailability, atomized about 81%, but if you apply the mucosal, about 56%. Okay, so there's a big difference in how you give the lidocaine. I'd be amiss if I don't bring up the Difficult Airway Society. If we go back, I mentioned earlier the Difficult Airway Task Force of the ASA really doesn't have an instruction book, an advisory, guidelines on awake intubation. The Difficult Airway Society of the UK does. They recommend that you not exceed 9 milligrams per kilo of lidocaine. I was certainly well below that in the example I gave you. The case I'm submitting or I'm presenting at WHAM actually had 8 milligrams per kilo, and the patient got toxic, lost consciousness and seized. But that, again, was a very toxic patient. Invasive blocks. I'm not going to talk about invasive blocks, okay? If you're curious, right now, at the moment, they're down, but on my YouTube channel, Airway on Demand, I've got videos of invasive blocks, or they'll be going back up soon. I can't teach you anything new about invasive blocks, okay? They've been around for 20, 30 years. There's nothing terribly new about them. You can get them online, and frankly, I haven't used an invasive block in probably 25 years. Patients don't like them. I don't like needles, so I'm going to stay away from it. The invasive block's absolutely useful. I think they're rarely needed if care is taken with topicalization. They're not practical in some of the worst airways. Some of the patients who are going to have terrible airways are the patients who are going to come in, they've already had radiation. They're going to be really tough airways. It's going to be really hard to get a needle through that skin and define the surface anatomy. This guy, there's no way I'm going to be able to reach his cricothyroid membrane. This woman with kyphoscoliosis, the same thing. And this gentleman who I could maybe use a needle on, but he's got this fun-getting lesion exactly where I'd like to do a superior laryngeal nerve block. So it's really not practical. No one's going to be happy with my sticking a needle through that thing. But the patient who arrives in your holding area looking like this may be the easiest patient to do an awake intubation on. They look terrible, but if you've decided to do an awake intubation based upon your decision tree tool, they have decreased salivation from both surgery and radiation. They probably have surgical analgesia in most of the anatomy. They turn out to be really easy to block. Sedation. This is Andy Ovasapien. Andy Ovasapien is the father of difficult airway management and especially use of the flexible scope in the United States, along with John Benemoff. Okay, I'd be amiss if I left out John's name. We lost Andy in 2010, but what Andy said about sedation for awake intubation is when planning sedation for awake intubation, the patient typically requires less midazolam than the anesthesiologist. And I 100% believe this. I had a resident call me for a pre-op one night and was talking about this awake intubation, and we were talking about it, and I'm going to give the patient midazolam and this, and I said, stop for a moment. Why are you giving the patient midazolam? And the resident said, to relieve the patient's anxiety, okay? And I said, the patient has no idea what you're about to do, right? You're going to explain to the patient, you are a trusted medical provider. They're going to put their trust in you. You're going to present it to them as if it's a routine, which it is for difficult airway patients. The patient's not anxious. You're anxious, okay? You're giving the midazolam for yourself. So let's try and reduce the sedation we give for patients to patients because we know that can lead to complications. And the whole point of what we're doing is to keep the patient awake and breathing. Do you want to steal a chair? Steal a chair. So sedation. We have different classes. We have anxiolytics, which calm the patient, may provide amnesia, but I said at the very beginning, that's not 100% necessary. Should not substitute for good rapport with a patient. And I'll tell you that I concentrate on my rapport with the patient. When I do a pre-op exam, I spend a lot of time with the patient just getting to know the patient. I don't know if we have any residents in the room, but I'll tell you one thing that a lot of clinicians know is that, if something bad happens, patients don't sue physicians for money. That's the way we deal with it in the society. They sue because no one said, I'm sorry, okay? No one explained things to them. And they also sue people they don't like, okay? So when I meet a patient, I spend a lot of time getting to know that patient. They like me, I like them, okay? That's a poor reason, but I also want them to trust me when we get to the operating room. So you have to have a good rapport with the patient, and that'll be most of your sedation. Analgesics supplement your local anesthetic blocks. They give cough suppression. We're going to talk about the agents that I use in a moment, but I'll occasionally use some opioid like fentanyl. I may give them 25 mics, 50 mics. I am not giving it to them for analgesia. I'm giving it to them because opioids are an antitussive. If you got a patient, everything else is going great, but they're coughing a little bit, 25, 50 mics of fentanyl will take it away, okay? It's very, very effective. And it's not going to sedate them at those levels. As a general rule, titrate carefully. Use as few agents as possible. Don't get into polypharmacy. Maintain the patient cooperative with you. Andy says the patient should be lightly asleep if unstimulated, but responsive to commands and able to carry out simple instructions. Nick Woodall of the Difficult Airway Society, sedation is not essential to awake intubation. Absolutely not essential if you've done everything else right. I will say that what the Difficult Airway Society says is that when you're doing awake intubation, that they kind of mandate you need at least 2 providers, one to just manage sedation. I don't think that's always practical in our realm. I think you can do it by yourself as long as you're very careful with your sedation. Benzodiazepines, I may give 1 or 2 milligrams of midazolam. If the patient has a benzodiazepine history, I might give up to 4. Propofol, not a good agent. It does not have a great window between sedation and comfort and apnea. So propofol is not a great drug to use for this technique. Opioids, as I said, supplement your local anesthetic, not a substitute, and mostly cough suppression. I have a little bit higher levels here, but I think practically probably 25 mics to 50 mics is really my limit. Remifentanil. Remifentanil is also a good drug, but I will tell you this. I told this story to the few people who were in the room early, that I used to use remifentanil for sedation for awake intubation, and I had a lot of apneic events. I had a lot of desaturation events, and I got rid of it because of that paper we saw earlier that said dexmedetomidine was probably a better drug. So this brash, younger anesthesiologist gets hired from Mount Sinai Hospital. She comes to Yale and she says, I use remifentanil. And I said, Jamie, I'll tell you what, for your sake, I will give it another shot. And what I found, once again, I was getting apneic events. And I switched back to dexmedetomidine. But what that made me realize is that it's not just the agent that you give. It's not just that one drug. It's the total technique. So maybe I give local anesthetic in a way that I get more absorption than she does, and I have more of a severe effect with Remy. We're all going to be different. So I've gone to dexmedetomidine. I called Jamie Hyman, a brash young anesthesiologist, because she was basically hired to take my job when I retire, okay? She happened to come from Mount Sinai Hospital in New York, where I was born and went to medical school, and now she's going to replace me in retirement, so it's kind of life cycle, right? She's a wonderful, wonderful colleague. Dexmedetomidine I'm using, gives sedation. No change in the hyperbaric threshold. We were all taught that you can't get apnea with this drug, with dexmedetomidine, but actually it does decrease the hypoxic response, so you have to be a little careful with it. It's not a beautiful, perfect drug, and you do get some decreased upper airway tone with it. So it's not the perfect drug. It does give some analgesia, and it does slow down the sympathetic nervous system some. So I really like that drug. My personal regimen, 30% of the time, I'll do some midazolam and fentanyl if it's simple. I might use a remifentanil once in a while if I already have it set up, but most of the time I'm doing dexmedetomidine. And 100% of the time, I'm not relying on sedation. I'm gonna rely on my blocks, and I'm gonna rely on my rapport with the patient and keeping the patient cooperative. Supplemental oxygen, I always use nasal oxygen. A lot of experts or enthusiasts are starting to recommend using high flow nasal oxygen. It does have some interesting effects, like it will, when properly applied, expand the pharynx, maybe give you a better view, and I really gotta get that video into this lecture. It is a lot of setup, but I understand why people use it. Maybe if you do have an apneic event, you'll have a longer safe apneic period. But that is a really important part, is always give oxygen. That comes back to the ASA difficult airway infographic, recommending throughout the entire process of airway management, you're giving supplemental oxygen. Awake intubation is not a rush job. If you decided you're doing awake intubation, you're thinking of safety, and safety is first. Nothing else matters. For example, the pressure of the operating room, okay? It's safety first. I do start my preparation outside the operating room. This is the time management issue, the procrastination. I'm gonna give my explanation and my glycopyrrolate in the holding area. I'm gonna start my topical anesthetics in the holding area, or maybe just outside the OR on a gurney. If someone complains about a delay, I've already gotten started. They're the ones that are sitting around the OR. I'm already doing my anesthetic, right? I hit the anesthesia start button on Epic. If someone complains about safety, let's go back to Dr. Goldberg. What is Dr. Goldberg? When I go to his office and he's doing some dental work, he takes a big syringe of local anesthetic and epinephrine, and he's injecting it into my mucosa. I think what we do is perfectly safe as long as we stay within those toxic limits. I want analgesia of the airway before I enter the OR, so I like to be able to place an oral airway at least 2/3 into the patient before I allow the patient to go into the operating room. If I'm going to do more invasive blocks, they'll be done in the operating room with monitoring, but I don't do invasive blocks, so it doesn't really matter. The key to awake intubation is to have a plan: explanation, desiccation, dilatation, topicalization, sedation, procrastination. And I'm thinking about adding to this maybe preparation, because there's a lot of little things that you have to get together. I travel around with a Home Depot toolbox, okay? And it's filled with all the little things that I'm gonna need, because I do a lot. Last week I did 3 awake intubations, okay? And that sometimes weeks are slow, and sometimes weeks I'll do 5. So I have all my tools all ready for this, so preparation. But we know it's not that simple, right? It's complex. Every patient's gonna be different. Certainly every operator is going to be different. And so, all I can say is that find your recipe, follow that recipe. I do the same thing every single time. And also, if you don't feel confident about your awake intubation, that's okay. I don't do regional anesthetic. I don't feel confident in my regional anesthetic. If I need a regional, I'll get a colleague who's really experienced in it to do it for me. Same thing with this, with awake intubation. Find a colleague who can help you with it. Take your time, cover the 3 areas, 1, 2, 3. Don't get hung up on the invasive blocks. You don't need needles, and your patients, they don't want the needles. So back to this guy who got transferred to Yale. He was an impossible intubation. And so we'll just watch the video of him finally getting intubated, He's been prepped. He's been watching the screen the whole time. And in goes the tracheal tube. He may give a tiny, tiny little cough. He grimaced a little bit, but not really coughing. We'll verify with end-tidal capnography, and then we'll put him to sleep. And we can see here, he gives us a little thumbs up in the corner. Okay, let me see if we have time. We've got 7 minutes. Okay, so I just wanted to back up and look at the second panel. We spent some time in detail on the first panel of the ASA infographic. Let's look at the second panel, which is the awake airway panel. And I'm going to cartoon this. So first of all, we're going to deliver oxygen throughout the entire process of what we're going to do. We're going to do an awake technique of intubation, or maybe we're going to ask for an elective surgical airway. Okay, maybe we don't feel confident, we don't have the tools for an awake intubation. We can have a surgical airway done by an experienced person in a controlled situation. If we have success, it's confirmed by end-tidal CO2, preferably waveform capnography. But maybe we fail. Maybe we fail to establish our airway. We can, at this point, consider calling for help. We have the patient spontaneously breathing, so we don't have to call for help, but maybe we call for help. And then we go into what I think is the most important part of this panel, which is the awake non-emergency pathway. That is the options that we have now that we failed our awake intubation. We can postpone. We're at an ambulatory surgical center. We say this is not appropriate for here, or maybe let's come back another day when we have the tools and the personnel to do it. We can try another device. Maybe we started with a flexible scope. We changed to a video laryngoscope of some kind. Maybe we call Airway Man. Who's Airway Man? John Sackles. This is his avatar on X. This is his avatar is for Airway Man. And it's the person in your practice that you trust with that airway. Come help me do this airway. Or next time the patient comes back, you'll have that airway. We can do an elective awake trach. So maybe the patient's all prepped, sedated. This patient, for some reason, whatever the reason is, has to have this procedure done. The example I give is a patient I had who had a difficult airway and a subdural hematoma. He definitely needed the surgery, and he got an awake tracheostomy. Maybe we don't have an Airway Man. Maybe we have Regional Man. Maybe I call the person in my practice who this patient who happens to have a difficult airway is in for a lower extremity procedure. Maybe I call Airway Man, or Regional Man. The last choice is the situation where surgery cannot be postponed or it turns into a crisis. I did have a patient once who started to panic during awake intubation, got very claustrophobic. And so what we did is we induced general anesthesia. But we had a surgeon who was at the neck, ready to go with a surgical airway. Now, this brings up a different topic, which is that when you evaluate a patient in holding area, you are not evaluating a patient as being a difficult airway or not. Okay, when you do your Mallampati, if you like that, your thyromental distance, if you like that, your oral aperture, if you like that, your range of motion of the neck, what you're evaluating is this patient at risk of difficult airway? Okay, a lot of those patients that we say are at risk are going to turn out to be easy, and that's okay. And many of these cases will turn out to be easy once we induce general anesthesia. But we've evaluated the risk and we decided that we have to take precautions with this patient. Okay, I have one last video in the spirit of practice, and I want to tell you that the prep of this patient was exactly the prep that I gave you that's on that card. Okay, so here I am. This is back, we've got about 3 more minutes. This is back in the 90s. And I've prepped my airway with glycopyrrolate, local anesthetic, everything else. And here I go with this. This is actually, for those of you who remember it, the ProSeal LMA. I don't know if you can hear it. I'm humming through it. But I'm going to skip to the next video. So this is 2006, and the Mac, it's called the Mac Series 5, was just introduced. And so I'm sitting in my office, and I did the exact same prep. That hand behind me was my simulator. Okay, I was alone in my office. And so I'm totally prepped, same I just told you. Here comes the tracheal tube. And I'm watching it on that little screen. I'm watching it with a video, external video. So the hard part is actually getting out the stylet. When the stylet came around the pharynx, a little bit of a gag there. It's hard to get those deep pressure sensors. Now I have to prove to you that this is in place. I have to prove to you that it's in place. So, blow some bubbles for you. Now, the other funny thing is that I walked out of my office, and this is honest to God a true story. I walked out of my office, and the first group of people I came across were a bunch of urologists, and what popped into my mind was, I wonder if they've ever done this. Anyway, thank you all very much. I have some extra cards up here. I'm happy to stick around for questions. Thank you.